Hi, and welcome to episode 79 of the Untethered podcast. Today we have Kelly Euperio joining us. Kelly's the owner of Boulder Valley Lactation in Boulder, Colorado. She is a registered dietitian and international board-certified lactation consultant with a special passion for helping breastfeeding dyads dealing with tethered oral tissues and other complicated feeding issues. Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Welcome to the Untethered podcast. I am your host, Hallie. I'm a certified orofacial myologist, feeding specialist, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, tethered oral tissue, and airway space. I challenge you to keep an open mind and join my mission to get this information out to the masses. Let's get started. Well, Kelly, thank you so much for joining us on the podcast today. I'm really excited to talk about all things IBCLC with you.
Great, thanks. It's great to be here.
So let's dive right on in and talk about, how you fell into becoming an IBCLC. What was that journey like for you?
So for me, and I think for a lot of IBCLCs, we become an IBCLC because of our own experience breastfeeding. And for some, it's like, oh, it was great. And for some, like me, it wasn't great. Now, my experience actually was kind of a little of both. Like, it was actually not too bad for me. My first daughter, she latched on right away. There was no pain. Everything was great. But then later she was diagnosed with failure to thrive. And I couldn't get enough milk in her. I, of course, blamed myself that I had low supply. She wouldn't take a bottle. And so I asked the pediatrician, what I should do. And he just gave me formula. And I was like, I don't know what to do with this because she won't take a bottle.
Right.
And I saw one IBCLC who told me, oh, you probably have enough milk. Most moms think that they don't have enough, but they do. So it wasn't helpful at all.
Right. Like, what do I do with that information?
So I got more help online, and there was no, I don't know, there were no like Facebook groups back then about this or, Instagram. It was all like Googling or, I think that Baby Center was super active back then when I had my babies, and, so I did all of these compensations for her. And, made myself have this huge supply. So, I could basically just squirt milk in her mouth, And I thought when I was becoming an IBCLC that that's what I'm going to help moms do is all these compensations because it just doesn't really work that well, And so then when I had my son is when I started my journey. And it was pretty much kind of the same with him. He latched on, but I got ahead of the game right away, made myself have a big oversupply so I could feed him to have just enough. So that was my journey to decide to become an IBCLC. And then in my first day as an intern with my mentor, she told me that she had me tell my stories about breastfeeding. And she's like, sounds suspicious. And then she's like, let's look in your mouth. And she looked in my mouth and she's like, oh, you're tongue-tied. Your kids probably are too. And that was my first day. And I was just like, what is she talking about? I definitely do not have a tongue tie. My kids don't have tongue ties, But then, probably within, 3 months, I was like, oh, they do. And that was my problem. That was the whole issue with breastfeeding. And I was able to compensate for them, but they never were able to competently breastfeed.
Yeah.
And that's why they weaned earlier than I wanted them to. That's why it was never, all of these things started coming.
It wasn't the ideal breastfeeding relationship that you were hoping for either of your kids.
Right.
Yeah.
And honestly, like, I didn't really even know that existed at that point. And I was becoming an IBCLC, you know?
So interesting.
And I thought that was the ideal, It's like,
I can totally relate because Lily was lip and tongue tied my first, and it was painful. It was uncomfortable. And I took her to an IBCLC who was like, oh, you just have to hold her this way. And like, of course, it's like when you take your car to the shop. I've talked about this on the podcast. Like I positioned her the way that she showed me. We propped her up. She fed beautifully. She transferred milk appropriately. And they were like, you're good. Never mind you. She was like first percentile. They marked her failure to thrive, like coming out of the hospital. Like my mama heart like sunk when I saw that on her like medical records that were all electronic and, on my phone, easily able to look at them, of course. Like, should never have seen that. And it was that whole experience too. I never knew that it was or could be different because I sought the help that I thought that I needed to seek. And then at month 13, we finally stopped because I was like, this is so painful. Like, I just can't do this anymore. And I was that stubborn mom who figured out ways to help my baby compensate, and I say stubborn mom because I know a lot of moms would have quit earlier, and I've worked with a lot of moms who have quit earlier because it's painful. It hurts, like to the point where like sometimes bleeding, cracked, like, it hurts. Like I would literally turn my face away from my child when latching her because it was so painful that I didn't want her to see my face because I'm like, I can't not react. So I'm like, how good is this that I'm, breastfeeding a child with this type of reaction or feeling? Like that can't be good energy to be sending into my child's body through my breast milk or just energetically in general. And this is where I go totally woo out at the other end. But
right, but it's not woo. I mean, there's hormones that change.
Oh yes,
You're feeling that,
Oh, yeah. There's always science behind the woo. Yeah, totally.
Yeah. So, before I became an IBCLC, I started my kids in myo. Like obviously I didn't have it all figured out, but I knew that much. I knew that, my kids needed that. And then within about, I don't know, probably 6 weeks of them starting myo, they both were put in ALFs, which I know is very similar to what your kids are doing. And we've gone from there. But, looking back, it's like I see so much and that I think is normalized. And, so my goal as an IBCLC is, to basically be the IBCLC that I needed, and to not normalize these things, I mean, so with my daughter, I look back at pictures and honestly, I mean, I think that if she would have gotten her tongue released as an infant, it wouldn't have done a thing. Because I don't know anybody around here that, 10 years ago was doing any sort of baby myo or helping retrain the tongue or do suck training or helping get a lip seal or anything like that. And I think if we would have just released her tongue as an infant, I wouldn't have seen any changes in her, I look back at pictures and of course she's one-sided. Always. She always has this looking this way, tilting the other way, like every single picture, I'm like, oh my God, how do I not notice this? But of course you don't. You're mom. You're like, even if I had a baby today, I might not notice it. But, so there's that. Constantly her mouth is open. Constantly, like in every single picture. When she's smiling, it looks cute. When she's not, it just looks like, oh, okay, as a mom, I thought, oh, she just has this heart-shaped mouth like her aunt on, and I thought it was just the way she looked, and, I normalized how much she slept. We all talk about, the bad sleepers as the ones that aren't, transitioning their sleep cycles. She was the opposite.
Lily too.
Yeah, really? She slept like 13 hours at night and then would take at least 1 3-hour nap a day, and then probably another 2-hour nap for
I had to wake her. Yeah, I had to wake her to eat. Otherwise, she wouldn't have gotten enough. Like it was,
right.
the doctor was like, no,
I,
you have to wake her throughout the night to feed her.
yeah,
Like, do not let her sleep that full 10-hour, stun. Like, and that was early on. Like she was sleeping 6 hours early on, then 8 hours. And I was like, wow, we have a great sleeper. And then they're like, you need to wake her and feed her. I'm like, well, that makes sense. Okay.
right. Yeah. Yeah, my daughter Kendall didn't sleep through the night, actually for a long time, but she was in bed with me a lot, and so it was really easy. She was, but she was just so tired all the time, and everybody of course was like, oh, you're so lucky, you get all that time during the day when she's napping. And I can't remember, I think by 8 months she was sleeping like 13 hours at night straight. And here I am not producing enough milk and not knowing why. And that's part of the reason right there is because most of these hours are sleeping. I don't know.
Then it also comes down to like how much effort is she putting out to feed when she does feed, and then how much is exhausting, right? It becomes like you're expending more than you're taking in, and so it becomes this vicious cycle. And it's like almost like this catch-22 where, well, what is normal sleep at this age, but also are they taking in enough nutrition, and and so I think that that's a really great point that does not get discussed enough.
Yeah, exactly.
Because Lily was that great sleeper, and I had to wake her, and she's always, we did end up doing like some form of sleep training like later on because things did change. But at the same time, she was the kid that she was just against all the rules. Like she was a belly sleeper. Tush was up in the air. She slept in that tripod, which I later learned is usually an airway thing. And even Mia, who was released at day 5 of life, was a belly sleeper. As soon as both my kids could flip themselves over on their bellies, they were belly sleepers. And I didn't fight it, because even if I tried to flip them back over, they found their way right back to their belly. And they both have beautifully shaped heads for kids who had neck preferences and so I'm not hating it, but but I know it's like a whole back to sleep campaign. It's a tricky thing. It's really a tricky thing.
So Kendall, when she wasn't sleeping with me, would sleep on her back, but she would arch her back, sleep like this on her back, where she was almost like on her side.
Yeah.
She was arched so much, which I know now is also airway.
Yeah. Complete head and neck extension. Yeah.
Complete head and neck extension while she was sleeping. And so
I'll have to go back and look at pictures, because Lily did sleep in our room for a very long time, and she was either in a rock and play, which I know is a big no-no now, but again, my kids had beautifully shaped heads and we were very lucky, nothing happened. But she was in a rock and play for a long time, because it was the best position for her to sleep in. Like she obviously was swallowing too much air and was uncomfortable. So that angled position was great for her if she was not like in bed nursing or like laying next to me. And as a first time mom, I was like so afraid of like crushing her and rolling over her because of like what, the media puts into your head, that I was basically like, oh my gosh, I can't bed share with her like for lengthy extended periods of time. But then I'd be so exhausted, I'd fall asleep and then I'd wake up and be like, oh my gosh, she's still in here. Oh my gosh. And I always, I tried to make sure she was like between my husband and I, so that like, she wouldn't roll off the bed. But then I'd also make sure like, well, what if he rolls over? I don't want him to roll onto her. Like we also have a dog. And so there's also just, I think, so many misconceptions about like bed sharing out there in general. And I know, we don't have to get into all of that, but for breastfeeding moms, I think it's an important thing to do in a safe way, because, and it's, again, they've normalized not bed sharing. They've normalized getting that baby away from mom and into a crib at such an early age, that I think that also can mess with obviously supply and, breastfeeding in general.
With bed sharing, it comes down to, most breastfeeding moms will bed share at some point. Mm-hmm. So we should be teaching them how to do so safely if they choose to do so. We can't just turn a blind eye and say never do it, because then nobody has information, about what is safe and what isn't safe. But anyway, I digress. But so with Kendall then, when she started myo, they looked in her mouth and they're like, wow, you have huge tonsils, and of course, she had been mouth breathing and, everything. And so I had a very similar experience to you, that her tonsils are now not as big now that she's in an ALF. Now,
Ooh.
we also did one other intervention, which she no longer has dairy and mostly no gluten. But so I don't know. And it was around that exact same time. So it's really hard to say, but I'm sure it was a combination of both.
Oh yeah. I mean,
Yep.
I think for Lily, if I cut out dairy, I would really have to get her to, she's like so limited, but expanding, that now I could see us going in that direction. But she's also my kid who's still very like hypersensitive to things. And so like, she'll smell something and be like, this is not cheese. Like, this is not this. Like, I'm not touching now the 10-foot pole. So like, until I can get her to take some alternatives, we've got her on some almond milk, and she's tried cashew milk and like some things like that. But I try to limit like milk. But we definitely still do some like cheese and butter and stuff. But yeah, I do feel like if we limited dairy with her and gluten, that would definitely help. But at this point, she's not mouth breathing. Her tonsils still look pretty small. So I'm kind of like almost waiting like to see like, will they flare up again this winter? Although she's home with us. So unless we travel somewhere or she ends up back in school at some point, like I'm not even sure that this winter will be like a good true indicator, because she's not really fighting off the traditional germs that you would in winter in the DC metro area. So
Totally. Yeah, so my daughter, I mean, she used to have her open mouth all the time, but now she doesn't. She prefers to sleep with tape.
Interesting.
So she's been doing it since she was 5. And what was really interesting is, our oral-facial myologist was talking to her about it, and she was like, oh yeah, I want to try it. And she started it and will not go back. And I've seen her like fall asleep in the car or without it, and she has her mouth closed, but she wants it on there. It's like her safety thing. But she knows how much better she feels. Yeah. And she was sleeping still 12, 13 hours a night at 5. And as soon as she started using mouth tape, she needed less sleep. She could stay up later. She started, which, I feel like a ton of sleep is super valued in our culture. Like, but I was so excited. I'm like, she doesn't need that anymore. She doesn't have to keep going to bed at 7 o'clock, and then get up at 8.
And she shouldn't have to, right? Like, I mean, at a certain age, like you shouldn't have to anymore. And I think that, again, it's become so normalized for kids to get like a certain amount of sleep, and even adults to get like X amount of hours. And as you get older, it might be less and But like you're saying, I think, and I've seen this recently, that the amount of sleep that a person needs at night really depends on your body. Like, there is no one like right number per se. And it's, what do you wake up feeling rested with? Like, because for some people that could be 6 hours, for other people that might be 8. So more so adults, not like young kids, they might need a little more. But yeah, it gets a really interesting topic. It's definitely not one that I am super well versed in, but I've been seeing like the buzz around this, and we're going to be talking to Ken Hooks in our Myo membership next month, who's a respiratory therapist, and he's been on the podcast. He goes deep into like the sleep studies and like what to look at. And I just think the topic is so fascinating, because it really all boils down to quality of sleep. Like, it's not totally how much, like, what is the quality of your sleep? So like, is it restorative, right? That's what it all comes down to.
Right. I mean, and without even a sleep study, I know that her sleep definitely got better, because the other thing that she was doing is she was coming into my room multiple times at night and telling me like, oh, I lost my Lammy, I need help finding it, or
something was
Mom, I just went to the bathroom. Like, okay,
thanks for the update.
Me, but she would always need like help finding something, and she stopped completely. Wow. Like day 1. And so I know that it was all mouth breathing. She wasn't getting, she wasn't transitioning sleep cycles. She wasn't probably getting deep sleep. She needed all of this, sleep. So, I mean, without even a sleep study, because we didn't have one, we actually tried to get one around that time. And we really don't have anybody in this area that will do pediatrics.
Interesting.
At least at that time. I think that we do have one person now that's okay. But
I mean, it's hard here too. I think unless the kid has like emergent sized tonsils and adenoids, they often are not sending young children for sleep studies. And I'm okay with that as long as that child is then getting the right behavioral type of treatments that they need. And when I say behavioral, I mean like myofunctional therapy is more like a behavioral type treatment, right? Not like, just throwing them into a surgery or something, unless they absolutely need that. But yeah, I think that if they're headed down the right trajectory, the right path, then you can totally skip the sleep study. Like if that's a big barrier, that doesn't mean you can't do other things. And I like to say that because I think so many parents are like, I don't even know where to go. There's no one here like around me who does this. And so again, like if it's not emergent, it's not always necessary. Sometimes they can be great to get insurance to cover certain things, certain treatments. And in that case, it might be worth pushing. But otherwise, like you're saying, like you could see the quality of life difference, like you're not going to see that on a sleep study necessarily.
Right.
So that's pretty cool.
Right. Yeah. And so then I know you wanted me to talk about my son too, which was a completely different journey.
Yeah.
With him, when he was a baby, breastfeeding was better. But again, part of that was I compensated from the very beginning. And latch was never an issue with either of my kids, but part of that is the type of nipples I have, and I see this now as an IBCLC. There are certain moms with a certain type of nipple. They're very elastic, really change shape easily, and that they don't have pain. It's not hard to latch onto. Like you could feed all the tongue-tied babies,
Interesting.
But again, so I actually didn't start my IBCLC journey until he was 2. And around that time, he was self-weaning, which I now know he wasn't actually self-weaning. I mean, there was all I went on a vacation and he took a lot more bottles, which was a lot easier for this tongue-tied baby. And so then he started to prefer the bottle a lot more, which sent us on a whole, down the whole rabbit hole. Yeah. And, before I started my journey becoming an IBCLC, I would have called that, he, weaned himself, but no, he didn't. We offered an alternative method more often, which was so much easier for him. But I actually, my first sign with him that something wasn't quite right, just besides all the compensating I was doing and the self-weaning and whatnot, was solids with him. He was what I called so picky,
Yeah.
He gagged more than my daughter. And oftentimes I would say like, oh, he's gagging on purpose because he's trying to, I thought, I didn't know, and then I would blame myself that he was picky. I was like, I think that I introduced more foods to her and I didn't introduce enough to him, and we were doing baby-led feeding, but, and then I was like, well, maybe I gave him more kid type foods early because she was eating some, I kept blaming myself,
Which is really easy to do as a mom. I mean, we do it all the time and we really need to not, but yes, I've been there. I understand. I do it too. Yeah.
Right. And then at 18 months, he had like 2 words. I'm like, okay. And our pediatrician said that because of that, we would qualify for early intervention. So we started working with an SLP. And he was able to work with her until he turned 3. So he pretty much worked with her. I think it took us a little bit of time before we got her started with her, but he worked with her for about a year with very little improvement. Very little improvement, like a little bit with language, which was probably developmental anyway, and then during that time, right before he turned 3 is when we started also doing myo, and I started like my wheels were turning and everything. But it was probably really good that he had been working with an SLP for a long time, and we were doing myo, and then so we got the release, and within it had to have been 2 weeks. Within about 2 weeks, not only did he just start talking, like saying more words and speaking like more sentences and all of that, he was saying sounds that they had been working on with the SLP for so long. And I specifically remember the K sound because my daughter's name is Kendall, and he would always call her Tendall or something like that. I don't think he could say L's either. So it was something different. Tendu. I think it was like Tendu.
Mm-hmm.
And it's like within 2 weeks, it might have even been sooner, but he could say her name. And I was just blown away. And again, I don't think it necessarily would have happened that quickly if we hadn't been in both myo plus an SLP, or, if it was an SLP that had been also did myo. But, but because he was primed for it and just couldn't quite, get the tongue up there,
Yeah.
it just happened so quickly.
Yeah.
So quickly.
And I've had cases like that. And I know like Richard Baxter has described cases like that with kids that he's released. And I know that there's like more research coming out on this. If there's just not enough, right? It's a lot of it's like case study or, reports. But yeah, I mean, we see this, like we see this in those of us that do us SLPs who also do myo, see this. And I know, like I always say at that young age, like under the age of 4, like traditional myo is 4+. So I'm always like, it's speech or feeding or whatever with like a myo twist. We're always working from like, what are the goals of myo and like, how can we achieve that with a younger child who may not be able to do everything that we can do with a child who's like the cognitive ability of like a 4-year-old on up. Like, how do we modify this so that like they can also achieve the same goals? Like, so they don't need myo when they turn 4, because we're doing toddler types of myo, right? And so I even teach on this in the course because I'm like, I feel like we need to be teaching SLPs, OTs, like anybody who is doing traditional therapy with these children. They need to understand what TOTs are and how to assess for them and how to diagnose them, like how to treat them when there's a pre and post-op frenectomy situation. Don't just send that child off for a release. It's not going to help them if they haven't been primed. Like he was well primed for it, right? But like you're saying, that's not like, had your daughter been released as a baby, you even said, like, I don't think it would have done much for her because
Nope.
You didn't know that we needed to have done anything else surrounding that release. I know she wasn't released as a baby. But I think that there's so much discussion amongst the tongue-tied Facebook groups. And like, I keep myself out of those these days because I'm just like, that is a rabbit hole I just don't have time for. And I just can't. I'm like, I can't police those posts, to be honest with you. I'm like, hopefully just, come listen to the podcast. You'll learn a lot here. But, I constantly see like, there's like this 50-50 divide of, well, we had a tongue tie release and it did nothing for us. And then as soon as somebody says, well, did you work with an IBCLC or an SLP or an OT or, have any body work or anything surrounding that frenectomy or, the labial and lingual frenectomy or blah, blah, whatever. And parents are like, no, we didn't do it. And it didn't work and da-da-da and whatever. And like, it's just, I'm like, I'm not going to argue with people, but I can tell you that most of the time when it didn't work, it's because they weren't primed. There was no pre-op or appropriate post-op. And there's a big difference between getting them ready for the procedure. And then also like, there's a difference between the active wound care. If like there are no sutures in place, like active wound care is its own standalone thing that you need to be educated in, separate from like post-op myo, right? So I know a lot of people send these kids in and they'll just try to like prescribe part of a program and they'll go in for the frenectomy and then they try to bring them out and continue that program with like extra tongue lifts. And I'm like, that is not how you can, keep the tongue from reattaching if there are no sutures in place. And even with sutures in place, like we can still have reattachment if things are not done, appropriately. So there's just such a larger conversation, I think, and a lot of education to be done. And I know that there's a lot more people who are starting to have these conversations and are starting to teach these things in their courses. So I'm really excited about that. I won't say a lot, there's a small handful of people, but that's also why for me, like when I'm teaching an SLP or OT to become a pediatric feeding therapist, like you better believe you're not going to leave my course without a solid foundation and instruction in TOTs and myo, because nobody has any business working with any pediatric feeding patient if you don't have a background in these things. You are missing the boat big time and really doing a major disservice to your patients. And I can't say, I know that a lot of traditional IBCLC programs also don't necessarily teach these concepts either. And I think it's kind of rampant across the board. And I know like a lot of us are like, we have to change this, but I thankfully get a lot of parents who listen to this podcast who are like, thank you so much for having that conversation or talking about this thing, or this helps me know like what to ask for, what professional to seek out. And really at the end of the day, I'm like, that's my goal. If I can just like impart this information and change a child's life for the better, if they're going to be going through this procedure, if they need that, I'm like, my work here is done.
Totally. So my mom is an SLP. And she actually retired about a year ago. And, but I started talking to her about this stuff, and it totally blew her mind. And she, once she started kind of digging into it and everything, she was like, oh my gosh, all of these kids that I could have helped, and she started looking in all of their mouths. She was a school-based IBCLC. And yeah. And, but now she's retired, and, she wishes so much that it would have been included in any sort of curriculum or anything, because there were so many kids, and once she started looking in mouths of these school-aged kids, she was like, they're almost all tied, and granted, though, she lives in an area where there was nobody to send any kids to within probably 4 hours. Wow. That has training, and so, but yeah, it's really, really sad that those of us that are working with either, babies that are struggling with feeding or kids that are struggling eating or speaking, like 100%, that should always be ruled out. But we have to realize that it's not just like this magical procedure that, once they get that tongue released, they're automatically going to be able to breastfeed. Right. Or, they're going to be able to talk, or, I mean, I feel really lucky that I didn't know about the tongue tie, when my babies were babies, because I was able to compensate for them. But I feel like maybe I would have gotten it released, and then I would have been in the boat of it didn't work. Mm-hmm. You know what I mean? Mm-hmm. But kind of by dumb luck, we started working with the SLP for a long time, before I figured out, they need myo. And then we did that, because I was preparing them to get their ALF. And then, so it was lucky. But even with that, so Dax is my son. He reattached a little bit. And part of it, I think, is because we did it at age 3 and without sutures. And so me trying to stretch him at age 3, like I was getting bit, and, elevations were definitely not easy.
Yeah.
But
really at 24 months, I understand.
So we are planning to have him re-released really soon, actually this winter. And so Dr. Lopez, you had him on your podcast. He is going to do a guided release with him. So I'm super excited for that. Yeah.
Yeah. So if you guys aren't familiar, Kelly's referencing Dr. Daniel Lopez, who is an osteopath, and he was on one of our earlier episodes, and he's a super cool doctor to listen to. Like he just
we're lucky to have him here.
The tongue to the rest of the body, which is so cool, because it's totally like up my alley and the things that make me really excited to talk about.
Totally.
That is awesome. So how is he doing with his feeding? Like, is he picky, selective, or is he like, has he gotten better with that? Is there still a lot of gagging, or is he okay with that now?
He's so much better with his eating. He's pickier than my daughter. But I would say if we're going to compare him to most, American kids, he's not that picky. He has celiac, which we also, figured out around when he was 2. That's a whole nother rabbit hole I could go into. But So he has to be a little bit less picky, I think. And so he has probably about, 6 vegetables that he really likes, but I'll take it.
Yeah.
you
So I've
know?
always said like, while Lily is more selective and definitely like hypersensitive to things, like she generally will try any vegetable. But she likes it plain. She wants it. She doesn't want it roasted. She prefers it steamed with like nothing on it, no flavor added. If I roast something, she'll be like, "What did you put on it? Like, did you roast it with like spices?" She's like, "What's on this? What are you trying to sneak me?" I'm like, and I'm always like, Lily, I will never sneak attack anything in here. Like, I always am like full on like, this is what you're getting, kid.
Right.
Because I know if she puts something in her mouth and she's like, whoa, like she'll even tell me, like, we'll try a new chicken nugget or something. So I'm trying to like food chain her back to like eating the grilled chicken she ate like before she was 15 months old, and had a really bad vomiting experience. And she'll try it. And if it has too much flavor, she just tells you if it's too spicy. It is too spicy. Like, and I'm like, huh, okay. And I'll taste it and I'm like, this is really bland to me. So it's so interesting because it just tells me so much about like how she tastes things. Like her flavor profile is completely different than mine. But again, like she'll eat like almost any fruit. She'll eat like a variety of vegetables and greens. So like she's getting her nutrition. She eats eggs, like she'll eat chicken apple sausage, like come on, kid. But not the organic version because the organic version is too spicy. And I'm like, you're killing me, kid. Like we're like an organic household, but at the same time, I'm like trying to like bring variety in. And so like at the end of the day, like she does have a well-rounded diet, like well-rounded, like nutritionally, like she's getting what she needs. So I think that's also part of why like I haven't thrown her into like therapy with an OT because I'm also like, well, let's see what else. Like with her ALF, she did become more willing to try things. She started like being like, well, can I try that? Because like my 2-year-old is like, I try that. I eat that. I eat what's on mama's plate. I eat what's on papa's plate. Like if I give her the same thing Lily's eating, because sometimes we do eat different meals. I'm guilty of that. Like my 2-year-old will always be like, Mama, I sit in your lap. Can I come sit in your lap? And like she'll jump up on my lap and just start eating what's on my plate. And I'm like this mom who's like, oh, gosh, I really should just stop giving her what Lily's eating and like start giving her exactly what we're eating. I just don't usually have it together by like the time they eat dinner, which is the bigger issue, to be honest.
Oh, I know.
Yeah. I'm like, my husband and I usually eat later than them. So we are that household. But I'm like, that's why I will never pass judgment on anybody else because I don't have there's no such thing as perfect. And I don't have my dinner meals together half the time. But yeah, no, I think it's so interesting because she's getting a good amount nutritionally. Her ALF definitely helped her become more adventurous, more willing to try new things. So she's added some new things in. She just added in like pomegranate seeds this past weekend. And I was like, I mean, to me, like I love the taste, but I don't love how it's like this hard seed that you have to chew at the end. And I'm like, she was all for it. So I'm like, it's just the things that she likes sometimes make no sense to me. Like there is no pattern. And so we just always go back to like, let's just try, let's just see if we like it, we like it. If we don't, like whatever. But yeah,
right. I mean, my son's at the age where if his friends like something, he'll try it.
Yeah. I think it's her sister has like influenced her 2-year-old sister.
Oh yeah. For my son, it's definitely his friends, his neighbor friends, who are 2 years older, so they're way cooler. And yeah, he also really likes to cook. And so I feel like I should include him in the cooking more often, but then it's also just makes it that much harder. Yeah. So I try to as much as possible because he will try things that he cooks. And sometimes even if it's one bite, I'm like, okay, that's good. What'd you think? Is it, but so I've tried to do that quite a bit with him as far as eating goes.
Yeah. I mean, it's like we can give all these suggestions all day long, but sometimes real life just, it comes down to real life.
Right.
It's realistic, but I love that. That's awesome.
Yeah. The thing that makes me want to get him released is that he's just, his ALF, we're having a harder time moving his jaw forward a little bit because it's still just held back. And so they're kind of just at a place where we're waiting for teeth to come in, but he still just has a little bit of a recessed jaw. And also he, something's, I mean, there's just something not right, where with his bladder overnight and I find that, so he's always been a nasal breather, but lately I've found that, and he comes in our bed in the middle of the night so I can look at him. But lately I've found that more often he's opening his mouth a little bit. And just looking at, like, looking at it, I know that he doesn't have full range of motion, And so he's totally on board with it. I wanted to wait till he was totally on board with it, because what'd you say?
How old is he now?
He's 8.
He's 8. Okay. Yeah, it's a little trickier when they're older. You really like want to get their buy-in so that they're willing to do the work before and after to make sure it's actually, worth it.
Right. So he's playing baseball right now. So he wanted to wait till baseball's over in case it's painful. He doesn't have to miss anything. So,
I mean, well, and Lily on the flip side, right? So we released her when she was 24 months old, and then her ALF went in like right before her 4th birthday and just came out. And what I've noticed is that like we're revisiting some of her myo now, like because I like want to make sure that it's really held in place. And I noticed that while she seems to swallow properly, her tongue was coming through her teeth to make that S. And I was like, okay, if your tongue is coming through for S, it's got you're not swallowing perfectly 100% of the time. I guarantee it. So I was like, let's jump you back into some myo. Like, let's reset on what we were doing before. And then I noticed, holy cow, like she's having a hard time elevating the posterior portion of her tongue up to her palate in the same way she could before she was expanded, before her palate was grown both forward and laterally. And then I was sitting here and I was like, okay, she's also choking on water. Like 6 months into her ALF appliance, like whenever she would drink a small sip, she would be fine, but a continuous sip of liquid through her straw, I would notice she would have like these, she's not really choking. She has choked like once or twice where we've had to like really hit her back hard because like really she just couldn't clear it. But usually it's like not like a serious coughing episode where it's like eyes are watery. She like is having a hard time clearing it, but eventually gets it. And I'm like, that's not normal. Like she should not be coughing on thin liquids. Like, why is it going down the wrong way? Why do you not have good control over like 3 sips of water in a row? Like that doesn't make any sense. When we graduated you out of myo, like you've never had a problem with that even before when you were tied. Like she couldn't figure out how to drink from an open cup when she was 2. And I was like, we got to do the lip. She can't figure out how to like, and we didn't release the lip, but that's another story. But she, now I'm pretty convinced, I've convinced myself that the posterior portion of her tongue does not fit into her palate. It can't reach it the same way it could before everything was grown and things shifted. And obviously with age comes growth too. So like the combination of like her growing plus us expanding and growing her palate forward and laterally, I'm like, I think we're probably headed for like a second release to like give her some more elevation posteriorly. And when she suctions her tongue, you can see the frenulum, like it is front and center, but it's really elastic and she can get the front 2/3 really well up into her palate. But I noticed like it's got to be something like more posteriorly that it healed to what her mouth was when she was 24 months old, and it worked for her anatomy until we expanded her. And now I'm like, oh gosh, now we have to go through this again. But I'm willing to do it because obviously I want her to be okay. I don't want her choking on thin liquids. That's dangerous. But yeah, it's interesting because I think we constantly have to step back and look at like, where are we now? How are things working now? And not assume that just because we've done one thing here or one thing there, that like we're set for life.
Exactly. I always talk to the parents that I'm working with their babies, if they get a tongue release, I'm, obviously really clear about how this isn't magic. This is, we have a lot of work to do afterwards.
Yeah.
Right. But then also this might not be the end of it after like this, like 4 weeks of what we're going to do or whatever it is for them, you do have to revisit it later. They might need a second release at another point, they might, and then they definitely might need either myo or something like that when they're old enough to do it. Same thing with my daughter. Like we constantly have to check in and do some myo for a few weeks, and it's, the things that change with her are so weird, Back before they got their ALF, she was the one that could swallow properly and my son couldn't, and then I'll test him again now And all of a sudden, like a year ago, she couldn't. I was like, what is happening? You could. This is one thing I wasn't worried about with you, you
Yeah.
know? But yeah, because everything shifts, because, you know, and so I had to reteach her how to
How
swallow.
to use your new anatomy, like how to, yeah. And that's also like for me personally with my myo patients, like we do a 3-month check-in after graduation, a 6-month, and then like definitely at a year, we're also checking back in to make sure like, are things still working the way they should? With the disclaimer to parents, like if things change, just reach out. Like we might need a little touch up or something. So I think that we all kind of feel like, okay, this is a therapy. We're going to do it once and then we're solid. We're good. Like when we're done, we've graduated. And when I was talking to Dr. Lenny Kundal, who's a dentist, you know, he was talking about the growth that children experience just naturally. Like forget all these appliances, like these children, like their mouths, their anatomy, it changes until they're what, like 18 years of age or so. Like we have to take that into consideration because like we're talking about, like you don't know how those just natural changes might impact their patterns and what they're currently doing. Now, if there's nothing interfering, then yes, the body adapts and we compensate when we need to, and you know, things don't seem to be an issue, right, in your everyday child. But for children who had any type of struggle from the beginning, whether it was feeding, latching to feed, I even tell parents like colicky babies, you know, messy feeders, hard time transitioning the solids, like any language delays, like anything like that, like those are big red flags that we should just be more closely monitoring their development to make sure that we're giving them the ability to function optimally. Because how much harder, and no one wants their child's life to be hard. We all want to give our child, the best opportunity to at an easy life, right? And so that's where I'm like, if we can just do like a few little things or a couple sessions here and there to like you're saying, kind of clean up what's going on and make sure that we're on track and really adapting to any new anatomical changes, any physiological changes. I think that's a topic that's also not discussed like at all. Nobody's talking about that.
No, I agree. Oh, one other thing I wanted to tell you that my daughter is in right now is, because I know you touched on this in another podcast, because I listen to other podcasts.
I love it.
She's in vision therapy.
Ah, yes.
Yeah. So 2 years ago, she came to me and said, that everything's blurry. And I took her to an eye doctor and they said, no, she's fine. So I was like, okay, are you just wanting glasses or something, kid? You're fine. Mm-hmm. So then she was like, all right. She didn't really say anything to me. And then last year during the school year, she was like, no, Mom, actually something's wrong. I'm blurry, like things go double sometimes. Sometimes it's blurry, sometimes it's not. So I took her to somebody else because I was like, okay, I'm not going back to that person again. And they're like, we can't lock in on a prescription for her. She does seem to be nearsighted, but we can't lock in on a prescription because sometimes she can focus, sometimes she can't. And, they did the test where they hold something out in front of you and then they bring it in close and you have to say when it goes double. Over a foot away, it was double for her.
Oh, poor thing.
Yeah.
Gosh.
And luckily, somehow she can read well. They're like, the doctor was like, I've never seen somebody that gets double that easily, who's grade level at reading. And, so she has now been in vision therapy since, I don't know, probably a little over 8 months now. And it's helping. But of course, I was talking to the eye doctor there and the vision therapist, about, have you guys talked about a connection with like her high palate and how everything above that, changes the shape of the eye socket and the eye, and they're like, oh, no, they're like,
you got Dale Lopez, you really should talk to him.
Right, exactly.
I mean, it's so interesting. Like this is making me think back when I was in high school, like out of nowhere, I all of a sudden started having trouble with vision. And my mom took me to our eye doctor, who's like very well known in the area and very, very highly sought after, like private pay, doesn't even take insurance kind of person. And, very, very knowledgeable. And I've even taken my kids there. And basically the message was, well, sometimes kids get extra stressed like around exam time. Like, is it exam time right now? And I was like, well, yes, we are like in, I don't know, it was like midterms, final, whatever. And
exam time.
it was exam, exactly. Well, now exactly, like it's always exam time. And they were like, well, the additional stressors of da 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 da. And like, of course, we all know stress impacts your health. So of course someone's going to go like, oh yeah, that makes sense. And then I don't know if I just learned to compensate better or what, but even to this day, like if I go into certain like stores that have certain lights, like a Nordstrom rack, like these, like there are certain lights that affect me that I can't manage as well as others. And I'm like now going back and like, I wonder if that's like related to everything else. Cause it probably is, duh. But yeah, I mean, it's so interesting to see how many of these kiddos have vision issues that we're working with. And thankfully, some of our parents have figured that out, and these kids are actually in vision therapy before they even come for a myo eval. But yeah, the connection is so interesting.
You say the lights. I mean, my daughter, when she was most adamant was when she started basketball, and she was in these gym lights.
Yeah, it's those like fluorescent, like those,
yeah. Mm-hmm. And I mean, it was horrible for her. She couldn't do it. She couldn't handle it.
Yeah. Like I will actually be in like a Nordstrom rack shopping, which hasn't happened in the past, 7 months, but like I would be in like a store like that, and all of a sudden, like I'd be like, wow, like I'm feeling like really lightheaded. And I'd be like, this is coming on, like I'm noticing it. I would have to, so my husband had this thing, and I won't really go into too many details, but like he passed out a couple times and he went to some specialists, and they're like, oh, you have this like vasovagal syncope, which is like literally like, we don't know what happened. So we're just gonna give you this random diagnosis that means nothing. And they're like, if you feel it coming on, get down on the floor and like squeeze your hands and feet really tight to like bring all the circulation back to you. Like, don't pass out. He's like, yes, that always works on the metro. Thank you for that advice. Which is like where it happened once, and or almost happened. And so I will notice myself, like, I'm like, okay, squeeze everything really tight. I'm like sitting in the middle of like Nordstrom rack, like squeezing my fist and like squeezing the handle of like the shopping cart. And it does help. But I'm like, why is this happening? Why do I even have to do this? Like this, something is, and when I go back to like a medical professional and tell them this, they're like, they just brush it off. They're like, well, you're fine. Like, how often does that happen? Only in those stores? Like, don't go there. I'm like, oh yeah, that's great. Great advice. Thank you very much. But yeah, I have to wonder, technically my vision is still like 20/20. I don't wear glasses. Like I have good vision. So everyone always just thought like, oh, Hallie's just stressed out, or Hallie's just, making something up, kind of a thing when I was a kid. I also have a lazy eye, which is a whole nother story, but so they always like wondered, like, is it harder for her to see? And I've had surgery on it 3 times over the course of my life, and the muscle never really seems to hold, which I also wonder if that like ties into the stressors on my vision system. Yeah, so I don't know. It's definitely a fascinating topic. And I know Angie Lehman and I think dove into the eyes a bit too on her episode with me. But we referenced back to Daniel Lopez's article, and that was where I was just like, oh gosh, like the interconnection between all this is fascinating, absolutely fascinating. So my question for you is like, how is that going for her? Like, is it actually helping? Do you feel like there's like more pieces to that puzzle that need to be addressed?
It's helping.
Yeah. And it's hard, right? Like vision therapy is hard, isn't it?
She hates it.
Yeah.
She hates it. And like, we have to do a lot of work at home, reminds me a lot of Myo. But it's working, but it's not, we're going to take a break from it after this session because she hates it so much. And we've learned a lot of the things that I'm like, okay, we can do this at home, know? Yeah. But it's not like a 100% helping, they've locked in on a prescription for her. So at least now we can do that. And so we're going to give her some time with her glasses just to then see, but, so I don't know, like it's helped. And she's not going blurry as much, and she's not going double as much. So it's better. I don't know. It's not like 100% better, but I'm the type of person who, I always want to know why, like, okay, so why is this happening to her? Yeah. And I mean, that seems as plausible as anything else, and like you said, the doctors are just like, oh, it just happens to some kids. Like, why aren't we looking into why more?
Like maybe if we know the root cause, like we can address that, and then these other symptoms will go away.
Right. I mean, I just don't understand that in our medical system in general. Why isn't the root cause looked into more?
I mean, I can't even tell you, like in grad school and even like when I started to work in the schools, I can't tell you how brainwashed I was to tell parents, it doesn't matter what the diagnosis is, we're still going to treat it this way. And in my opinion, I'm like, not only were we like gaslighting parents and being like, sorry, like this is unimportant information. But well, first of all, knowing a diagnosis can absolutely change the course of treatment, maybe less so like in speech therapy or language therapy, but definitely like on a myo side and airway side and TOT side, you know, there's definitely, when you're getting to the medical side, dysphagia, swallowing disorders, like we need that medical information. Those,
Right.
what is the root cause of this issue? Because is this the primary problem or is this a symptom? You know, like, let's stop slapping Band-Aids on all the symptoms to deal with the root cause. And then, oh my gosh, what do you know? Other things start to miraculously go away and things fall into place. And this person is now like more rested and more energetic and they feel better and they never knew their quality of life could be so good. And like, this is what I hear from adults, like adults who finally have myo and their tongue ties released if they have a tongue tie, and maybe they go through like adult, you know, growth appliances for expansion work. And I've literally had like adults go, holy cow, like I've lived 35, 40, 50 years of my life. I never knew it could be different. And I'm like, that's sad. Like I was that person too. I get it. But like at the same time, I'm like, holy cow, like we are so, not only are we failing the kids, we're just failing society as a whole if people think it's okay to feel this way, going through life this way. So I'm like, we can all do better. And
Yeah,
yeah.
totally. So, I mean, I did the myo with my kids while they were doing it.
I love
And
it.
then around that same time, one of the dentists that does good releases near me, you know, said, I want to try something out on somebody. And I was like, oh, you can do it on me. I'm tied and I don't care, you know? And he was like, okay. And so he's like, well, I mean, and he's one that requires myo for adults. So it's great, you know? So I, you know, was more diligent about, you know, doing it with my kids and whatnot. And, but I was like, but I don't have any symptoms. I'm definitely tied, but I don't have any symptoms, you know? And he's like, okay, well, that's fine. Right. He just, you know, he's like, I just want to try out, you know, a couple new things on somebody and I don't want to do it on a baby. I'm like, yep, valid. So I got my tongue released. And the first thing I noticed was I didn't wake up with like a neck pain every day. I had been having my husband pick out a new mattress or saying like, we need to get a new mattress or I need a new pillow, or we had gone through 4 mattresses in 5 years.
Oh my gosh.
Because I kept saying like the ones that we're picking out are crap. I wake up with a kink in my neck and like all day I'm like rubbing it all day, you know? And I remember like always kind of feeling that way and always thinking like I had to have my pillow in one exact certain way, or, you know, I would wake up with a hurt neck, you know, and right away that was gone. That was automatically gone. And I always thought that you know, this goes back to the myo, but I actually always thought, you know, I put my tongue in the right spot. I'm like, oh, my tongue's up. It's supposed to be up. Great. But then when I started myo, I didn't realize, oh, so a mid portion of my tongue is up, but then the front part is on my teeth and down, you know? So I always thought like, oh, I'm doing everything right. Nope, wasn't. And, but then, you know, I started learning more about the breathing and airway issues, and I started really retraining my breathing. And I do some bike races, and my favorite bike race is Pikes Peak. And without changing my workouts or my training really at all, just getting the tongue released and really focusing on nasal breathing. And I did a lot of buteyko exercises while on the bike and learning more nasal breathing while on the bike and everything. So just that stuff, I decreased my time, which it's like a 2-hour ride for me, by 30 minutes.
That's incredible.
Right. It was crazy.
Wow. Holy cow.
Know? Yeah. I mean, and honestly, I say without changing my training, but I probably trained a little bit less, to tell you the truth, you know?
That's incredible. I mean,
yeah. And so whenever you talk about athletes and how, you know, I'm by no means an elite athlete, but it makes such a difference. It really does. Like just the, I think changing my tongue posture, especially, and just my tongue being able to get up all the way, just opened up my airway so much.
Yes.
And then the addition of learning more how to breathe and everything. Yeah.
How cool. I mean, we hear stories of it all the time, but I'm like, I think until like people hear more stories and more stories and more stories like that, they'll finally be like, okay, maybe I need to do this, or maybe I need to look into this. But how cool. I mean, how cool. Like that.
Right. It's not too late.
Yeah.
It's not too late when you're an adult.
I mean, and interestingly that you say that, I've had some therapists enter like our Myo program and say, I have a 7-year-old who I'm thinking about, is it too late for a tongue tie release? Or like, at 7, no, like, please send, prep them. Let's do this. Like, how can we support you? Because I'm like, we have adults like, in their 60s and their 70s who are getting tongue tie releases. I know I've not had these patients, but I know of colleagues who have treated patients that were in their 80s, and to see the impact and the improved quality of life and the ability to breathe better, like you're talking about, and adding in some like breathing re-education, like it's never too late. It is never too late. And hello, like how else do you extend life? Well, by not killing off all the brain cells. So like, let's be breathing properly so that our brain can last as long as it possibly can. And, because the more that we mouth breathe, the more brain cells we kill. It's pretty much, that's pretty much what's going on here with sleep apnea. So yeah, I mean, we can address sleep disorder breathing at any age and frenectomies at any age. So I love that. I love that message. That makes me so happy.
And I didn't even think I had any symptoms.
Right, exactly.
So many of us adults think, oh, I don't have any symptoms. It's not related to that.
Yeah, like that adults who come in, right, and like we assess their child, and then the adult's like, wait, do I have that? Wait, I think I have that. And then I'll be like, well, your tongue looks a little tight underneath, but I mean, we'd have to evaluate and figure out like this, that, and that. And they'll even say like, well, I don't have any symptoms. Like, I'm fine. I'm like, 45 and I've never had a problem with my tongue a day in my life. Like, I'm not a picky eater. I'm not this, or I'm not that. And then you start to ask them other questions and you're like, wait, that's related? Like that's.
I have the same conversation with parents of babies.
Yeah. Oh yeah. And that's where I'm like, it's exciting though, to be able to educate and to also give hope, because some people have been living with issues for so long that's impacted their mental ability to function in daily life. Like there's like a mental health, component to it. But yeah, it's incredible. It's so much further reaching than just releasing a tongue. It is, and doing some myo. It's quality of life, like daily ability to function in your daily life and be that human being that you want to be for yourself, for your family, if you have one. And so, yeah, I'm obviously very passionate about this topic.
Me too.
But I love it. I love the work that you're doing. I love, the success that you've had and that your kids are having. And I love that everybody's on their own journey. I think it's a perfect example of how it's so individualized and what it looks like, from one sibling to another, and even like the parent, coming into the mix. It looks very different. And so I think that the more stories we can share, the more beneficial it is for our listeners, whether they're parents or professionals in the space, or people who are, well-versed in this versus people who are just starting out on this journey. I think it's really, really helpful to share these stories. So thank you so much. Is there anything else you want to add that we haven't covered?
I don't think so. I think
no?
we
Awesome.
did a great job.
Thank you, Kelly. It's been a pleasure having you. Thank you for sharing your story and your kid's story with us.
Yeah, thanks for having me.
Thanks for listening to this podcast. If you want to hear more of these myo, TOTs, airway, and feeding related episodes, be sure to leave a review on Apple Podcasts or pledge a small amount on patreon.com/the Untethered Podcast. If you found value, others in this space will too. So be sure to share this episode on your social media platforms and join us over on Facebook, on my Facebook page at Hallie Vulcan Biz, on Instagram at Hallie Vulcan, and you can head over to theuntetheredpodcast.com to grab a copy of the show notes, where you can also subscribe to be kept up to date on the latest podcast episodes.